afternoon, everyone, and welcome to today's webinar on the role of state health leaders in addressing neonatal abstinence syndrome. My name is Lee Forbush, and I work at the National Institute for Children's Health Quality, also known as NICHQ. And this webinar is the third webinar in our Infant Mortality Expert Webinar Series. And we're delighted to be partnering today with ASTHO, the Association of State and Territorial Health Officials, for this webinar. I'd like to take a moment to give a few tips on general housekeeping. First, please note, because of the size of this webinar, we will have all participants muted for the duration of the webinar. And so instead, we encourage all participants to ask questions through the chat box. You'll see we have both a chat box and a Q&A box. Please do use the chat box. We're also encouraging everyone on the webinar to receive their audio through the computer rather than through the phone. And so if you're experiencing any technical difficulties with the audio, please call Amal on the number listed on the slide for any technical assistance you might need. As a reminder, all participants will receive a copy of the slides and recording at the conclusion of the webinar. So I'd like to turn it over to Scott Burns, the President and CEO of NICHQ, to introduce today's speakers.
Well, good afternoon, everybody. Good morning to perhaps some or many of you, and welcome to this great turnout today for this very timely discussion around the role of state health leaders in addressing neonatal abstinence syndrome. I get to introduce the folks who will be speaking today, and I'm going to go sequentially here with who you will be hearing from today. First will be Christi Mackie. Christi is the Chief Program Officer for Community Health and Prevention at the Association of State and Territorial Health Officials, ASTHO. She supports state public health capacity there as well as advocacy. She covers multiple programmatic areas, including injury prevention, which actually is where the work of the opioid epidemic is housed there at ASTHO. She joined ASTHO 2 years ago from Nevada's Department of Health and Human Services, the Division of Public and Behavioral Health. Christi obtained her Master's of Public Health from the University of Nevada, Reno. Our second speaker is Dr. Jay Butler. Jay is the current president of ASTHO and is also the Chief Medical Officer and Director of Public Health for the Alaska Department of Health and Social Services. He is a graduate of the University of North Carolina Medical School. He's completed clinical trainings at Vanderbilt and Emory, and he maintains clinical board certifications in infectious diseases, internal medicine, and pediatrics. He's authored or co-authored over 100 scientific papers and medical textbook chapters in many different topic areas, and he's an affiliate professor of medicine at the University of Alaska, Anchorage. He's completed over 23 years of service as a U.S. Public Health Service medical officer. He's participated in a number of emergency deployments. He just has an incredible career. From 2010 to 2014, he was Senior Director for Community Health Services at Alaska Native Tribal Health Consortium in Anchorage. He previously served as Chief Medical Officer of the Alaska Department of Health and Social Services from 2000 to 2009, among other positions in his past career. Next speaker is Morgan McDonald. Dr. McDonald is the Assistant Commissioner and Director of the Division of Family Health and Wellness at the Tennessee Department of Health. Morgan is board certified in internal medicine and pediatrics and received her undergraduate and medical degrees from Vanderbilt. She's a fellow of the American Academy of Pediatrics and the American College of Physicians. As Assistant Commissioner, Morgan facilitates prevention efforts across the state in Tennessee, including WIC services, chronic disease prevention, early childhood initiatives, injury prevention, among many others. In addition to clinical care, she's focused on program management, education, workforce development, and a number of other arenas, including quality improvement. She served as a primary care clinician in vulnerable communities for over 10 years. Prior to joining the Department of Health, Dr. McDonald also served as an assistant professor at University of North Carolina and then at Vanderbilt University. Welcome to Morgan. And our speaker who will wrap is Zarnaaz Bashir, and she joined ASTHO in January of 2017 as the Senior Advisor for Strategic Planning and Evaluation In that capacity, she's responsible for working collaboratively with the executive director, the board, and the leadership to develop and execute ASTHO's strategic and operations plans, coordinates a performance management system that evaluates organizational performance and oversees national cross-cutting initiatives to ensure they are aligned and executed within the organization's strategic vision. Prior to joining ASTHO, Zarnaaz was the Vice President of Health and Wellness at the National Recreation and Park Association. She received her Master's of Public Health from the George Washington University School of Public Health and Health Services with an emphasis on health promotion and disease prevention. I think I said Zarnaaz was our concluding speaker, and I am not correct. It is Ellen Pliska. My apologies, Ellen. Ellen is the Family and Child Health Senior Director at ASTHO and is responsible for leading the activities of the Family, Maternal, and Child Health portfolio. Previously, Ellen served as the Family and Child Health Director and Maternal and Child Health Senior Analyst at ASTHO. Prior to joining ASTHO in 2007, Ellen served as the Cervical Cancer and HPV Policy Fellow at Women in Government. She has a Master's of Health Science from the Johns Hopkins Bloomberg School of Public Health. Wow, what a cadre of speakers, and I'm going to turn it over now to Christi.
Great, thank you so much, Scott, for the introduction. And for most of you who know me, I'm always thankful for those who are willing to take on the role of introducing each speaker and covering their bios. So at any rate, thank you all so much for being on today's call. Please allow me to introduce Dr. Butler, who's the Chief Medical Officer and the Director of the Division of Public Health at the Alaska Department of Health and Social Services, and he is also ASTHO's current president. So just to give you a little bit background before we get started, as a tradition with ASTHO, we have an annual election where our members, our state health officials, elect a peer every year to become the president. And among one of the many roles that they serve for us, they also issue a challenge that generally is intended to unite and rally state health officials, our affiliates, and really try to work and promote cross-sector partnerships to take action on a critical role or a critical urgent public health issue. And the challenge really centers around public health approaches to preventing a number of different areas, a number of different issues, pardon me. So this year, as ASTHO's president, who was elected in 2017, Dr. Butler issued a challenge that centers around public health approaches to preventing substance misuse and addictions. During his presidency, Dr. Butler was able to create a strategic framework around substance misuse and addictions that is intended to take a public health approach where you take a look at primary prevention, secondary prevention, as well as tertiary prevention around substance misuse and addictions. Clearly, this challenge also addresses the growing opioid crisis, which remains a priority for many of our members at ASTHO, as well as nationally. So, as you all know, the opioid crisis impacts the maternal and child health population at multiple points across the life course. In particular, the use of opioids during pregnancy, which we know can result in a drug withdrawal syndrome that we call NAS, or Neonatal Abstinence Syndrome. Every year, it's estimated that about 20,000 children are born to opioid-dependent women in the United States, which translates roughly to one baby born suffering from an opioid withdrawal every 25 minutes. So, you know, just to take a look at the issue, we've heard through our partnership with NICHQ, so ASTHO's partnership with NICHQ, where we've worked with them on our infant mortality, on their infant mortality coin collaborative, where ASTHO's been able to focus on pre and interconception care, where we've been working with state teams and also their health officials, where we've been hearing that neonatal abstinence syndrome is and has been a growing concern of theirs for some time. So, you know, I think when we think about that, that's where we started to take a look at the space where clearly you can prevent neonatal abstinence syndrome in this space of pre- and interconception care, but we also needed really to begin to address the area where we know is still an issue, where babies are still being born with this syndrome. So ultimately, what we wanted to do is, take this public health approach and be able to share with you, this comprehensive space to address neonatal abstinence syndrome or the epidemic. And we're thinking of this in that public health space, population-based space, where it takes multiple stages of prevention, cross-sectoral partnerships, across state programs, state agencies, legislatively, also very importantly with our healthcare community as well as community organizations. So looking at this collectively and taking that population-based health approach. So without further ado, I will stop talking, and I would like to present to you ASTHO's president, Dr. Jay Butler. Take it away, Jay.
All right, thank you, Christy, and good afternoon, everyone. Let me just start with a quick sound check. Can you hear me okay?
Loud and clear.
Okay, fabulous. Greetings from Alaska. I want to thank NICHQ for the opportunity to speak with you today and to give you an overview of the ASTHO President's Challenge for 2017. In case we get cut off, let me just give you the quick summary. This is the 30,000-foot view, and if we are going to appropriately address neonatal abstinence syndrome, it needs to be as part of a comprehensive approach to addressing substance misuse that is multi-tiered and multi-sectorial. And I will not say a whole lot of detail about neonatal abstinence syndrome, but then I'm going to turn it over to Dr. McDonald, who can drill down a little more into some of the details of what public health practice and programmatic interventions are available for addressing NAS. I don't think I'm advancing the slides. Maybe someone else is. There we go. So Christy mentioned a conceptual framework that we put together to address public health approaches to substance misuse and addictions. And this is a variation of that is very specific to opioid misuse. In public health, we like to talk in terms of prevention. We also like pyramids, so here we've got another one. But the real point of this is to highlight the multi-tiered approach that's needed. I was recently asked by a colleague that I hadn't seen in some time, so what's the answer to the opioid problem? And I thought for a moment, and I said, well, the answer is to start by recognizing there is no the answer, that it requires a multi-pronged approach in doing multiple things at once, not only to prevent the bad outcomes that are happening every day, including the next case of NAS that just statistically will happen before I'm through speaking today, intervening to treat people before they get to that point, and then also primary prevention. How do we reduce the burden of substance misuse and addiction in our country? And these are issues that are fairly new to public health, but the paradigms of public health practice are not so new. When we look at acute health event and control and prevention, this really fits with the tertiary prevention. That is, the interventions that are related to harm reduction, things like naloxone provision and syringe and needle exchange programs. We also have a long history of chronic disease screening and management, and this aligns well with the secondary prevention measures that include screening and getting people into treatment. But ultimately, it's the primary prevention measures that will have the greatest long-term impact. Although it will take longer to make a difference, we've got to address the continuing influx of people who are living under the burden of addiction into the population by ideally averting the substance misuse that too often leads to addiction. And this involves reducing the need to self-medicate or to use medications, Also controlling the access to addictive substances, whether that's through measures to reduce access to illicit drugs or how we prescribe opioids. And we also need to promote protective factors. I just came from a meeting that was an announcement of a citizen's petition to ask FDA to review the data available as a step towards removing some of the ultra-high potency opioids from the market. We have a lot more information now about what is appropriate and judicious opioid prescribing. And yet we still have products on the market that in one pill will exceed 90 morphine milligram equivalents, which is the level of concern as defined by the CDC guidelines. So let me spend a few minutes talking about what each of these tiers might look like and what we can do, and then for each, elaborate a little bit in terms of some of the things we've been doing in Alaska. So in terms of harm reduction or tertiary prevention, we can increase access to naloxone and providing public and professional education on administering naloxone and managing overdose. At the policy level, we can eliminate the liability and financial barriers, particularly as it relates to civil and also criminal liability for someone who has witnessed an overdose, administers naloxone, and appropriately calls 911. And many of our states now have addressed authorization of standing orders, have furthered third-party prescribing, and also authorized pharmacists to be able to practice independent dispensing of naloxone. We can support clean needle use, and I know for some people this is still a controversial issue, but it's well documented that this is a way to reduce the transmission of bloodborne pathogens. I want to stress, neither clean needles nor naloxone address the underlying problem. So I think of these as like a tourniquet. They stop the life-threatening hemorrhage, but they are not definitive medical care. And so it's important that we recognize that these things alone will not solve the problem. Many of our states are looking at increasingly high rates of hepatitis C infection, particularly among people under age 30, and much of this is driven by self-injection drug use. I think everybody on the call is probably aware of the HIV cluster in Scott County, Indiana, 2 years ago, and I think that could happen in many of our communities. So to address availability of clean needle use, we need to end drug paraphernalia laws that restrict access and be able to support these programs, whether it's through sales of syringe and needle or through exchange programs. And I think in particular, there needs to be some focus on ending this continuing federal prohibition on actual purchase of needles and syringes. We've made some progress in terms of reeling back the complete prohibition on supporting these programs using federal funds, but there still actually is a prohibition on the actual purchase of needles and syringes. Just an example of something we've been doing in Alaska. Thanks to a 5-year SAMHSA grant, we were able to purchase naloxone in the prepackaged nasal spray and have assembled those into overdose kits that include 2 doses of naloxone, some gloves, a barrier if rescue breaths are needed, as well as instructions in what to do in the event of an overdose. We've been able to assemble these kits with volunteers, and one of the more moving events that happened was at the end of an evening where 2,000 of these kits were assembled, somebody asked everyone in the room, many of whom had come from a long day at work and spent their evening putting these kits together, how many people here are alive today because someone administered naloxone to you? And about half the room raised their hands. And I realized what a sign of hope for people who are struggling with addiction, that if a life is saved, it can be the beginning of the path to recovery. So far, we've distributed about 7,000 of these kits. We are not tracking them closely because we want them to be in the hands of people who are most likely to witness an overdose and be able to intervene. But nonetheless, we're aware of roughly 40 cases now where a life has been saved through administration of these kits. And roughly half of those have been administrations by members of the public. But as I said, a tourniquet is not definitive medical care. So let's talk about treatment. First thing we need to do is remove some of the barriers to treatment. And when I talk to people in the recovery community, one of the biggest barriers besides finding someone who will provide treatment is overcoming the stigma that's associated. And so we need to reframe the conversation about addictions and increase awareness of addictions as chronic health conditions, not moral failings, not bad habits. We need to also recognize that there's opportunities for intervention in habits like drug experimentation during the teen years, but particularly when we're talking about the opioid epidemic, it's different than other drug problems because so many people first become dependent on the drugs when they're using them on the recommendation of a trusted healthcare provider. We need to improve access to preconceptional care. I really appreciate Christi already bringing up the issue of interconception care, which is important for mothers who deliver as they enter into treatment for addiction, but also as we provide care to women who are addicted. We need to increase screening and diagnosis, making expert available and incorporated into healthcare and social services. And we need to improve access to withdrawal symptom management and support for recovery, including standardization of assessment and treatment of NAS. There's barriers to therapy that include more than just stigma. There's also lack of standardization in terms of how withdrawal is managed. You'll notice I use the term withdrawal management rather than detox. I think that's, I'm not trying to be politically correct. I think that's actually a term that's much more descriptive because detox sounds like something you go to LA for and get a high colonic and boy, you're cured in 2 weeks and there's nothing more to worry about. That is part of what's led to our problem is we fail to recognize that just going to a dude ranch for a few weeks and not using doesn't address the underlying condition of the brain that is involved in addiction. This issue of what is addiction, I think, is really critical. And I like this quote from Anna Lembke. Anna is a addiction psychiatrist at Stanford University. She's the author of the book Drug Dealer MD, which I think really nicely summarizes some of the changes in medicine over the past 20 to 25 years and calls out some of the prescribing habits that may be contributing to some of our substance misuse issues. And she's addressing particularly that question of, well, why can't people just say no? Why can't they just clean up their lives? And she points out that if you see somebody who continues to use despite their lives being totally destroyed, losing their jobs, losing loved ones, ending up in jail, nobody would choose that. No, if you could just say no and avoid that, it would happen. So it's clearly beyond this individual's control at some level. And I think many of us in healthcare still need to learn that. I have to admit, as an infectious disease provider, I saw all the bad outcomes. I wasn't even aware that people were getting through and living in recovery, in part because of the stigma that made patients hesitant to even tell me about their past. But we have to address the issue of why is it that a patient can sit there, look me in the eye, and say, Doc, I'm never going to do that again, and they're back in the emergency room 2 nights later because they did it again. It's not because they were lying. It wasn't because of a lack of will, but it was because of how addiction drives the cognitive and behavioral functions of the brain, and that's expressed in disastrous ways in the lives of people who are addicted. Primary prevention, what can we do? Here is, I think, probably one of the most important things is promote healthy families, and I'll add healthy communities, and increase resiliency. So this includes promoting maternal and early childhood health programs, prioritizing pregnant women for screening and access to treatment, and utilizing some of the tools in the CDC's 2016 technical package, preventing child abuse and neglect. We also need to influence the environment so that the right choice is the easier choice, including reducing the supply of opioids in our communities. And to promote judicious prescribing as well as to reduce diversion of prescription opioids, we can develop and utilize user-friendly, robust PDMPs. You know, what I hear from so many providers is the challenge of using the PDMP. When they've used it, they generally say it is a fabulous tool, but too often it is problematic for patient flow. So we really need PDMPs that work well in the clinical environment. We also need to support criminal justice reforms that focus more on dealers than users. I like to quote the federal prosecutor in Anchorage that commented to me, I spent 20 years locking people up because I thought they were just stupid, and then I realized, no, they were just kind of pissing me off because they were doing the same thing and again. And what they needed was treatment. What I need to focus on is the people who take advantage of those with addictions. And then finally, support safer pain management and judicious prescribing. And this involves expanding public and professional education, including evidence-based pain management guidelines and non-opioid pain management strategies. We know that many people use opioids after an injury because they're so available in our communities. They know that in the past they've gotten them from providers. A friend may loan them some. And one of our outreaches in Alaska that we're about to launch is really focused on not sharing is caring. And finally, we need to develop safe medication storage practices and drug return programs. We've been able to promote drug disposal bags in Alaska, and I think this is, can be very useful in rural and frontier states. Here's Andy Jones from our group demonstrating one of those drug disposal bags with some oxycodone that he got at a dental appointment. The bags contain an activated charcoal, and the drug is deactivated and can actually be disposed of in the landfill. The lieutenant governor behind him looks rather concerned. The other point I'll make from this screenshot of the Juneau Empire is our governor introduced an opioid bill this session that really focused on some of the practices related to the amount of opioids that are dispensed. I've talked to people from Europe, and they're frankly stunned why after, say, a wisdom tooth extraction do people get 60, even 90 oxycodones when, you know, they're accustomed to getting acetaminophen or even another non-steroidal anti-inflammatory, which for other people my age on the line, that's probably what you got as well. So at least if we're going to use opioids, dispense them in smaller quantities and use the smallest dose possible. Opioids are a tool, and just like a chainsaw or a gun, it is a tool that has uses but can also be very dangerous. We have to apply it in the right place. And too often in pain management, what we need to do is hang a picture on the wall, and we're using a pile driver to put the nail into the wall, and we're doing more damage than good. The other point I have to make, if you haven't been to Alaska, is only in Alaska would the changes in the fishing season appear on the front page of the state capitol paper above the fold. So what will success look like? Ultimately, we'd see reduced deaths from drug overdose and fewer cases of neonatal abstinence syndrome. We might see declines in motor vehicle crashes that are related to impaired driving and fewer self-injection related infections due to HIV or Hep C. And ideally, we'd see less unintentional injuries and self-harm related to drugs and alcohol. And I think we really have to add to this list also reduced rates of incarceration due to violence related to drug use, as well as incarcerations for simple use. On the further horizon, the real goal is to reduce rates of drug misuse and addiction, particularly underage use, and we would see lower rates of referral to child protective services. I think in all of our states, we are seeing more of a burden on child protective services, in a large part driven by substance misuse. Ideally, we'd see less interpersonal violence, self-harm, and child neglect. And of course, we want to keep in mind, as I said, opioids are a tool, so there are situations where they're appropriate. So the ultimate goal, when it comes to prescription opioids, was that we would prevent excessive prescriptions while addressing appropriate pain management for those who need it. Cross-sector collaboration is key. You'll see a large number of partners here. So it requires not just public health agencies, but also working with departments of law, departments of public safety and corrections, our medical boards, the healthcare system, including providers and hospitals and clinics. I think this is particularly important when we talk about neonatal abstinence syndrome, that our hospital administrators, as well as the medical staff, need to be working together to have unified plans of how to manage patients with neonatal abstinence syndrome. The last cross-sector collaboration I want to highlight, and there's plenty more listed here, is community coalitions. I really think the tip of the spear occurs at the community level. And I've seen this in several of our communities where community members have gathered together, have included elected officials, have included families of people who are struggling with addictions, have included providers, both medical and behavioral health, have included law enforcement, and most importantly, have included people in recovery. We at the state level can support those activities, and we need more engagement at the federal level as well to help support the work that is really carried out in our families and in our communities. And in closing, I just want to point out what I think is probably obvious to everyone here. Our approach needs to be more than just molecule specific. We have lots of issues to deal with, and particularly when we're talking about neonatal health, it includes legal substances. Fetal alcohol syndrome continues to be a challenge. So addressing how do we reduce consumption of alcohol, particularly among pregnant women, is a critical issue. 8 states, including mine, have legal retail marijuana sales. We have a lot to learn about the health effects of marijuana during pregnancy. I am concerned about the perception that marijuana is a harmless substance during pregnancy, and we really don't know enough to be able to support that. Many other issues here that it's always important to remember that when these drugs are used by the mother, they are being used by the neonate as well. So in closing, I just want to make one final point specifically related to opioids, and it's related to what I just said about when the mother uses, the child is using. It's critically important to remove the stigma associated with neonatal abstinence syndrome. I just want to really encourage everyone to push back when you hear people say that a baby is born addicted to opioids. There is a physical dependency, and that's why we see the physical manifestations of withdrawal in the newborn. But addiction is a chronic health condition involving the brain. It may take years for recovery. And I think we're putting these kids in a very disadvantaged situation if we start them in life with a label of addiction. So I thank you for your time. I look forward to your questions, and I'm going to turn it back over to the moderator, and I look forward to hearing more from Dr. McDonald.
Wonderful. Dr. McDonald?
Great. Thank you, Dr. Butler. Really appreciate your really painting a framework for national priorities and how we think about NAS. And that fits really nicely with what we're doing in Tennessee as well. There we go. All right, and so over the next 20 minutes or so, I'd like to really lay out a discussion around these 4 objectives. So I'd like to discuss the evolution of NAS surveillance processes and data in Tennessee, and then describe an approach to NAS using the levels of prevention that Dr. Butler just described. And then I will move to a description of some of the strategies that we've used specifically in Tennessee that have really arisen from local partnerships. And then finally, I'll share some of our lessons learned and our approach to NAS. Okay, and so to begin really our story of NAS surveillance, what we see, I really want you to focus kind of on that left box, so our data 1999 through 2010, that's what we were able to see in 2012. And that was based off of what we could pull from our hospital discharge data set, and as is the case in most places, our hospital discharge data set lags by 18 to 24 months. And so although we were seeing certainly a rise in the 2000s, we weren't seeing the significant impact that our partners were telling us. And so when we eventually, 2 years later, were able to pull that data from 2011 and 2012, we found, lo and behold, yes, they were right. What they were telling us was that NAS was a significant problem, particularly in certain parts of the state. But what we really began to realize was that we weren't getting an accurate picture and that we needed a more real-time surveillance system. And so I'm going to switch to the next slide. So many on the call are obviously familiar with the definition of public health surveillance, which is an ongoing systematic collection, analysis, and interpretation of health-related data essential to the planning, implementation, and evaluation of public health practice. And so for us, we really needed that early warning system, or at least a timely warning system. We needed to also be able to generate more information around where this was geographically more of a problem, populations that it affected disproportionately, and we needed to be able to understand really finer details of the epidemic that was emerging. And so from that, we grew an NAS surveillance system. We in the state of Tennessee are very fortunate in that our Commissioner of Health does have the authority to add conditions to the reportable diseases and events by law. And so we do not require additional legislative approval for the addition of those conditions, and we do change this list every year. We change this based off of infectious disease surveillance needs. We also change it obviously based off of other priorities such as NAS. We have used this also to mandate overdose reporting. We've also used it in the instance of reporting neurologic birth defects related to the Zika crisis, and we've used this for lead surveillance as well. And so since we implemented the NAS surveillance system with a standardized case definition, we saw from 2013 to 2016 the data that you see presented on this slide here. And we have seen a slight increase from 2013 to 2016, and I will note that we have done some validation testing from that data in the early years and validated it with our hospital discharge data through 2015, and it actually correlates quite well, over 90%. And so we do believe that we are getting accurate reports across the state. But what you'll see is, yes, a slight increase in the number of cases from 2013 to 2016. Likewise, a slight increase in the rate, but this was not statistically significant. And kind of painting this picture with the early year picture, I think it's really important to see that we've really seen a leveling off of NAS over the last several years. And that's been important to show to our partners both in the community and the legislature as well. So some key takeaways from our surveillance summary up through 2016. So although we've had, like I mentioned, the increase in cases over the years, that has really stabilized, and we've had a stable NAS case rate. We have had geographic variation in the location of cases. Our highest prevalence is in East Tennessee by far, and it really follows kind of a graded prevalence, if you will, from east to west. We've had a significant increase in time and over time and exposure to legally obtained prescription medications. One of the great things about our surveillance system is that we do have flexibility to change it to be able to measure really those questions that have helped us drive policy. And so one of the things, as mentioned here, that we've been able to measure is what substances infants have been exposed to during pregnancy. And so what we've seen is as we think, increased availability of MAT in particular has become more available to pregnant women. That's what we're seeing in our NAS data as well. And so nearly 3/4 of women now, actually almost 80%, are exposed to at least one prescription drug. So about half of those are prescription medications only. 26% has been a mix of prescriptions and illicits. And then obviously a decrease in exposure to illicit substances. And so there has been definitely a shift from one type of substance or one type of exposure to another as we've been able to measure that through our surveillance system. So I think it's important to recognize that although we've been able to highlight and prioritize based off of our surveillance system, there are also things that surveillance really couldn't tell us. And again, speaking to the importance of our partners. So Medicaid in particular has been a strong partner in addressing NAS. We know that 92% of infants in Tennessee that are born with NAS are covered by Medicaid. We also know that the average cost is significant. It's over $44,000 in that first year of life compared to $8,400 for a non-exposed infant on average. We also know that average length of stay is 21 days compared to 3.5 days. About 84% of mothers in this TennCare data set are ages 21 to 34. And so really based on their data, we know that this is not a teenage epidemic. It's really an epidemic that's affecting older women to a larger degree. So applying that prevention framework to some of our data, I'll look here at, again, our levels of prevention, primary, secondary, tertiary that Dr. Butler's already described. And we really, as we were thinking about NAS, again, we want to focus on primary prevention. So before this baby winds up, before mom winds up pregnant and before this baby winds up in the nursery, we want to prevent addiction from ever occurring and prevent unintended pregnancy. Obviously, we are also involved in secondary and tertiary prevention, but we're really trying to focus our efforts on those two priorities in primary prevention. So our strategy, again, here you'll see that primary prevention repeated here. So preventing addiction, preventing unintended pregnancy, and then coordinating our response with our partners. So as we think about preventing addiction, really we have focused on decreasing opiate supply. Our state legislature has been very responsive to ask for help in this area. We have a fair bit of authority. We actually now have a licensing practice for pain clinics, and that has decreased our pain clinics by about from over 300 to just over 100, so by almost 2/3. We've received significant authority for regulation and oversight of those clinics and prescribers. We've also had a prevention effort around count it, lock it, drop it, so proper disposal of medications, and an access to mental health resources. We partner with our Department of Mental Health and Substance Abuse in making those referrals happen and really messaging those treatment resources. Of course, we still have a dire need for more treatment resources and mental health resources, knowing that that lack of mental health treatment often leads to addiction. And talking to our mental health commissioner yesterday, even with the additional funding, she feels that only about 1/4 of people who struggle with addiction across the state of Tennessee will really be able to have access to treatment. That's up from 1 in 10, but still to think that only about 1/4 of people could have access at any given time of those that need it, it says a lot. Our second priority has been on preventing unintended pregnancy and expanding access, particularly to family planning services across the state. And I'll talk a little bit more about that in my next slide. And then thinking about how we coordinate response has been really mission critical, certainly coordinating our response across the department, but also coordinating across agencies and external to government as well. So the surveillance response that I mentioned previously really came out of an NAS subcabinet that consists of the State Department of Health, the State Medicaid Agency, Department of Children's Services, Department of Human Services, Department of Education, and our Medicaid agency, as well as children's advocacy groups and providers across the state. So that has been critical. We meet every other month or more often as needed to review data and to talk about coordinated response and planning for addressing the epidemic. This is an example here of our NAS surveillance report. We actually generate a report every Monday that goes out with our weekly case count and how that compares to the years prior. And then every month we generate this report that's present on our website. And what I really wanted to emphasize here is, yes, the data collection. So you can see in those blue bars the cases per week of the current year, and then the lines above it are those years prior. And so you can see that we're tracking pretty close to the years prior. We also highlight maternal source of exposure. But the thing that I most wanted to highlight is that we really make sure that we put prevention with our surveillance data. We know that this goes to community partners. We highlight those community partners. And we also, I'm going to kind of show you on the back here, we highlight those prevention opportunities. And so to women of childbearing age, effective ways of preventing unintended pregnancy, to providers, links to prescribing guidelines. And we've also highlighted one key question in particular. And we can see here some additional data that we put out every month that is where we're seeing the most cases. And so we have NAS cases by region at the bottom there, and then maternal sources of exposure broken down in more detail at the top. And so to give you a little bit more information about some of our family planning partnerships, we really have focused on expanding access. And this has been in the form both of educating women and community partners, and in providing additional services outside the health department. And so our health department has primary care and family planning services in well, we have family planning services in all 95 counties, and we have primary care services in the majority of our rural counties, but not necessarily our metro counties. And so as we've been thinking really of getting outside our own doors, we have partnered with some non-traditional partners. We were approached by county sheriff and a drug court and jail, particularly in Sevier and Cott County and Eastern Tennessee, a couple of years ago, with the idea that they wanted to also offer more opportunity to women who may not otherwise have an opportunity to consider their role as women in preventing NAS. And this has been an opportunity for our nurses to be able to go into settings such as jails or, in some cases, MAT clinics to provide really factual information about NAS and what causes it, and also to provide an opportunity for women to be empowered to make their own decisions about both substance use in the future and seeking treatment, as well as about family planning. Those education efforts also developed into some partnerships with delivery of services in some cases in jails, in some cases actually providing transportation to county health departments during or after incarceration. And again, our focus has been on voluntary decision-making and making sure that women have as many options as they would want in a timely way, and that there has been no coercion through our services. And so that's been extremely important, and we, through several external audits have actually been evaluated, and we found it extremely important to make sure that we've had external eyes on our program, really to have community input as well as external stakeholder engagement in that process. And so we've had audits by Title X that have been actually very supportive and have taken our curriculum to other states. We've also had an external evaluation by an academic partner, which has interviewed participants who have participated both in our education and service delivery model. And that report is forthcoming, but has also showed really an emphasis on empowering women to make decisions that they feel like are appropriate to them. We have, in the same way, begun to approach MAT clinics. There has been really some interesting dialogues and barriers that I can talk through at a later time, or if there's questions later. But again, seeing that as an opportunity to, again, empower women who may or may not be thinking about pregnancy or who might already be pregnant, and thinking through their options to prevent NAS. We've also partnered, we have an interesting an interesting new law that came about last year that has enabled pharmacists now to dispense over-the-counter contraception. And we have partnered with the rulemaking and essentially development of policies and practices around that. And we have found that this has been a tool as well to really highlight opportunities for preventing unintended pregnancy and therefore preventing NAS. Again, we're focusing on our highest risk population that's been identified both by surveillance and by our partners, and really trying to minimize barriers to effective contraception in a culturally appropriate way. I have here a map of these NAS prevention partnerships, and this was really us surveying our counties. As I mentioned, we have seen this program grow from a very local initiative and to one that has been appealing across the state. And so this partnership idea, particularly with the jail, started in East Tennessee, and county director talking to county director talking to county director, it has spread across the state. And what we can see, July of 2017 is an increase even from then. And so we've got close to 50 counties that are providing education or in a planning phase around NAS prevention opportunities with expanded family planning. And we have approximately 40 counties that are actually offering those services outside the health department or bringing women into the health department who might not otherwise be able to access those services. We have seen a change in rate in NAS cases. This is 2015 compared to 2013. And just to note that about 43 counties had either no change or a decrease in rate in NAS. And obviously there's multiple factors contributing to that, in addition to what I just mentioned. A couple of, I should have labeled this slide kind of FAQ. These are questions that I get frequently. So our sources of funding include Title X funding, service reimbursement through Medicaid and otherwise. We do have some Medicaid infant mortality funding that has been helpful in supporting this as an interagency funding agreement, as well as some NCH Title V funds that have gone for services and education. Our organization as a state health department, we're a mixed model, so we have direct reporting and funding structure from our rural health departments, but our metro health departments actually function independently and by contract, so in very close relationship with us. And obviously we have partnerships with multiple professional associations, community health centers, FQHCs, and faith-based clinics. We as the state also provide training in family planning, whether that has to do with device placement, but we particularly make sure that we co-deliver training. If we're delivering training on device placement, we don't leave out the client counseling, knowing that it is so important to have that tiered effectiveness client-centered approach to all contraception. And then we've also been sensitive to public messaging around family planning services, knowing that the understanding of that is quite variable and can be interpreted in different ways. And so we've been very careful to emphasize the voluntary and reversible nature of those long-acting reversible contraceptives, but also, again, to be emphasizing that this is about empowering women to make decisions themselves to reduce NAS likelihood in their families. And then obviously we've done some provider outreach through our state associations and to MAT clinics and pharmacies. So some key messages and some lessons learned. So when we are referring to long-acting reversible contraception, we use the term VRLAC, voluntary reversible long-acting contraception. And we really feel like this language is important to communicate our priorities to clients and funders and stakeholders, and to really emphasize the importance of including a spectrum of options with, again, that personalized tiered effectiveness approach to contraception. So we do not have an agenda to increase utilization of VRLACs. We have an agenda to expand options to women across the state for family planning services. We do want to emphasize a flexible approach and not just as we've always done it within the health department, and really the essential nature of contraception and contraceptive access in addressing public health priorities like NAS or like infant mortality or like neurologic birth defects and Zika when that was a significant priority for the state. And then we realized that it's been important to have ongoing conversations with our partners to recognize both what they're seeing as drivers of NAS, but also to lay out our priorities with them. And so we've had some important conversations with patient advocacy groups who we want to maintain an open dialogue with. And we want to know if, if our best laid plans and policy and communication might be interpreted differently at an individual level and be able to respond to that. And so it's been important for us to have advisory committees as well as ongoing informal relationships and conversations really to make sure that we're staying the course where we want to be. It's a little advanced. A couple of resources here. These are online access to our reports. So those reports that I just showed previously around NAS are weekly, monthly, and annual reports in that top link. The bottom link is actually our Medicaid or TennCare data around NAS for those that might be interested. And just to acknowledge that this has taken a tremendous amount of work from a variety of internal partners as well, and certainly appreciate the support of our commissioner, Dr. Dreisner, our Chief Medical Officer, Dr. Reagan. Dr. Miller has been the champion of NAS surveillance and has been the one who will notice if the hospital stops reporting and needs to reach out to a new coordinator to report that. And so really that boots on the ground and ability to provide technical assistance to other states as well has been mission critical from Dr. Miller. And then Dr. Warren, our Deputy Commissioner, really birthed a lot of the vision of this from the NAS subcabinet and made it happen. So that is all of my slides, and at this point I will hand things off to Zarnaaz and Ellen for your comments.
Thank you. This is Zarnaaz Bashir. So I'm going to be talking about a tool that is currently under development at ASTHO. It is our National Opioid Framework. And so this is a tool that builds off of our President's Challenge that Dr. Butler talked about earlier, and we're really excited about it. But it's currently underway. It's a public health approach for state and territorial health officials to use to respond to the nation's opioid crisis. So essentially what it is a tool to help state and territorial health officials organize resources within and across jurisdictions and engage in strategic conversations and really strengthen their comprehensive response plans that encompass multi-program government-wide approaches to combating opioid misuse. What the tool is not is a list of everything that state and territorial health officials need to do within their state to address the opioid epidemic. What it is a list of the things that need to be done within a state, and for state and territorial health officials to take the lead on ensuring that the items within the framework are being addressed, whether they're taking the lead on it or one of their partner organizations is taking the lead on that as well. And so what you see on the screen right now are a list of our key strategies within the framework. As I mentioned, the framework is currently under review and being drafted. So when I submitted this slide, there were 5 strategies, but we currently have 4 now. And what you see on this screen, monitoring and surveillance, prevention and education, reducing and managing access to opioids and treatment and recovery, are the 4 strategies. That last strategy you see on the slide there, expanding the evidence base, got encompassed into the second strategy listed in that bulleted list. And so these key strategies are strategies that we want to ensure are being carried out, or that state and territorial health officials assure are being carried out within their state. And each of these strategies is further defined by promising approaches to preventing opioid misuse and an online compendium of resources to help them as they engage in that. So what you see on the screen with the strategies listed there, they're divided out by objectives, policy, programmatic, and partnership tactics that health officials can engage in order to meet the strategies. And we also provide a compendium of tools and resources and state stories and evidence supporting those particular strategies. So the framework was developed based on a review of state opioid plans. We looked across the entire United States, did a lot of searching on Google for state opioid plans. And based on that and our President's Challenge and a lot of national frameworks that currently exist, the National Governors Association, the National Association of State Alcohol and Drug Abuse Directors, Trust for America's Health, there's a lot of good plans out there that we use to really inform this framework. And we also sought input from a diverse group of stakeholders and experts representing state health agencies, national organizations, and federal agencies as well. And so we're hoping that our members can use this as an opportunity to expand collaboration across sectors and engage in strategic conversations with their partners, but also to help them organize their resources and identify their gaps in planning. I had a recent conversation with one of our regions representing 5 different states. They were really excited about this framework and are intending to use it to build their agenda for a regional opioid meeting that they're holding in October, but are also using the objectives and the tactics within to help them align their work across regions and identify some of their gaps in planning of where they can do a better job. So we were really excited to hear that. And the next steps for this framework is that we're hoping to have a soft launch of it at our annual conference in mid-September, but really launch this sometime in the fall. We do anticipate it's going to be a fluid document. It is going to be online, and we're going to be continually updating it based on the feedback that we get back from members and others. But we also want to continue to populate it with useful tools and resources and state success stories to help our members as they're responding to the nation's opioid crisis. We're also going to be tracking how the framework is going to be used. But in regards to NAS, within the strategy listed up there on prevention and education, that second bullet up there, we do point to promoting maternal and early childhood health programs and prioritizing screening and access to treatment for pregnant women with opioid use disorder and improving care for infants with NAS. So we want to be sure that that's highlighted in the framework, and we'll have some resources and tools and some great stories to go with that as well. So with that, I'll stop there and hand this over to my colleague Ellen to talk about some more resources.
Thank you so much. So I'm going to discuss a little bit more about what ASTHO has developed around neonatal abstinence syndrome-specific resources. In early 2017, ASTHO, with NICHQ support, developed an NAS collaboration framework, which was part of an original supplement to a 2015 issue brief around how state health departments can use the spectrum of prevention to address NAS. And so the framework's intent is to aid in structuring stakeholder discussions at the state level to better understand how collective efforts can prevent in utero opioid exposure and impact the incidence of NAS. And so ASTHO developed this case study to document one state's experience going through this framework with the goal of refining the tool for other jurisdictions to better identify collective goals and gaps in current approaches to this issue. And we found that this framework can be very useful for multi-sector state, regional, and local partners who can benefit from working together on this issue. We are also in progress on an upcoming issue brief, also as part of our COIN work with NICHQ. We are developing an issue brief on addressing NAS and substance use disorders from a life stage framework. And this is going to be framed through the role of state health leaders. We will be highlighting 5 states and their efforts, so that'll be coming out within about the next month. And we'll make sure that NICHQ will send it out to everyone who will be on the webinar as well as partners. And then finally, I wanted to just highlight some resources that we have. These are some websites that we have on the ASTHO website, specifically our main page on prescription drug misuse and abuse, and then a more specific page where you can find all of our NAS state stories, issue briefs, and other materials that we have developed. And then because we've gotten so many questions relating to our work around increasing access to contraception specifically and the linkages between substance use disorders and other groups, I decided to put this link up here as well because we do have some programming as well around substance-exposed pregnancies and family planning in the pre- and interconception period. We also, and I didn't put this up here, but we'll send out a link afterwards, are partnering with the Alliance for Innovation in Maternal Health, or AIM, which is a national program supporting states and health systems in their efforts to reduce maternal mortality by 1,000 deaths and severe maternal morbidity by 100,000 cases. And as part of this, AIM works with states to implement maternal safety bundles. And one of the safety bundles that they did just implement or develop is obstetric care for women with opioid use disorders. And so this is available online, and we'll make sure that NICHQ sends it out. Afterwards, we're very happy to be partnering on that effort. And with that, I would like to turn it back over to the moderator.
Great. Thank you so much, Ms. Mackie, Dr. Butler, Dr. McDonald, Ms. Bashir, and Ms. Pliska. We'll now open the session up to questions from the audience. If you haven't yet, please chat in any questions you have for the speakers. We have received several questions already. We hope to get to as many questions as possible, but we might not be able to get to everyone's question during the session. I'd like to turn it over to our moderator for the question and answer portion, Pat Heinrich, who is the project director for our infant mortality COIN and brings a wealth of experience with infant mortality, and she will be directing the questions that we get from the live audience to our speakers today. Thanks, Pat.
Thank you. So we do have some great questions. I think all the questions that came in before the webinar were answered beautifully by our speakers, so thank you so much for your presentations. We do have one question, starting with a question for Dr. Butler. Why is fewer cases of NAS defined as success? If one of the goals is access to substance abuse disorder treatment, and evidence-based practice for the treatment of an opioid use disorder is medication-assisted treatment, such as methadone and buprenorphine, sorry, I can't say that. These two medications are highly correlated with NAS. But treating the birth mom is so important. Shouldn't the development really be about plans of safe care for the infant and caregiver? Wouldn't that be a better indicator of success than reducing NAS?
Yeah, thank you for that question. That's a great question, because what I'm going through is kind of the long-range goals of what we're trying to achieve. And I think you raised a great point about the difference between goals and indicators. And sometimes the terminology that we use for indicators can be nuanced, if not misleading. And another example that comes to mind is we've been trying to bring down our chlamydia rates. But you know, how do we ultimately do that? We do more testing, which actually makes our rates go up. Our long-term goal is to prevent chlamydia infection. So I appreciate that comment because there are many process steps along the way that if we consider NAS rates as our month-to-month or year-to-year indicator, it may be very misleading. The ultimate goal, though, is to reduce the number of children who are born with substance dependency or substance effects.
Thank you. I have about 4 questions for Dr. McDonald. First one is from Ellen Mason. Her question is, what case definition did Tennessee use for surveillance of NAS?
So I think that's a really important question because we get calls all the time asking for ICD-10 codes or ICD-9 codes in the case before 2015. And we actually used a clinical case definition, which was exposure to substances and withdrawal in an infant. And so it's been really important for us as we've been communicating with our hospitals that this isn't just about exposure to a substance and it isn't just about, infant behavior, and certainly it's not just about did I give medications for withdrawal or not. It's about, again, that exposure and the symptoms in the baby, regardless of whether medications were used as an intervention. So hopefully that addresses the question to some degree.
I think so. Thank you. Thank you. A question also for you, Dr. McDonald, from Lisa Gorman. Are you providing universal screening for all infants born in Tennessee?
Universal screening for NAS? Or
I believe that's...
Or substance use in pregnancy?
Well, it did say infants, so perhaps NAS. And Lisa Gorman, if you want to chat in exactly what your question was, we can first address it as far as NAS.
Probably answer both. So, I mean, there's not a universal screening. This is a matter, again, of clinical recognition from providers and then training providers that if they recognize it, they need to report it. So that's maybe the answer to one arm of that. And then the other one, so recently ACOG did change their recommendations to recommend universal screening. We don't enforce that. Certainly we, with any mechanism, but certainly we encourage following ACOG guidelines.
Great. Thank you. From Amanda Waldrop, are men given the same education and information around NAS and contraception as women in Tennessee?
Yeah, I really appreciate that question. We have really made a concerted effort to reach out more towards men, and so initially some of these education sessions did start focusing more on women, and we have changed that focus to be more comprehensive. And I would say that is also in sync with our federal guidance from Title X in general to expand access to family planning services to men.
Great. And last question for you from Deborah Barnes-Josiah. Can you say a bit more about the types of groups that make up your community partnerships?
So it depends to some degree as to who is there locally. And so often those include Department of Health and might include Health Council in a county, might include a local drug coalition, might include a sheriff's office or a jail in some cases, might include MAT providers, although they've been much harder to engage as partners. I'll just mention that. Might include pharmacists, might include medical providers. Certainly on a state level, our Perinatal Advisory Committee and our Infant Perinatal Quality Collaborative have been extremely helpful from an addressing NAS perspective, as have our academic partners. Like I mentioned previously, those agencies within our NAS subcabinet, both at a state level and a local level, have been very helpful. And ongoing conversation with DCS, for example, has been really facilitated in mechanisms like the NAS subcabinet meeting and even in instances of things like a child fatality review at the local level or a local drug partnership.
Thank you. Want to give the other speakers a chance to comment on that same question. Dr. Butler or anyone else on the call have any other suggestions about community partners? Okay, then let's move on to our other questions. From Mary Wachura, she asks, are perinatal mood disorders contributing to NAS? So I'll let anyone willing take this one. Lee, can you hear me?
Yes, we can.
Okay, just want to be sure I didn't get lost. Anyone willing to talk about perinatal mood disorders?
So I think perinatal mood disorders, I think probably referring to postpartum depression and the like. And certainly mood disorders are correlated with substance abuse, and so thinking comprehensively about mom's health and the health of the family is one thing that we want to make sure that we maintain focus on. I think it's been helpful, even in pediatric practices now, to be able to bill for screening for postpartum depression, and again, providing those services to the entire family. And that's one way that we've been able to partner as well with Department of Mental Health and even DCS to a degree.
Thank you. All right, we have a question from Larissa Rim. All states have different laws and regulations, which we just talked about a little bit, in regards to what can be done once a baby is born. What is being done about expecting mothers into monitoring systems starting during their first or second trimester? There are a lot of barriers set up to prevent healthcare workers to being proactive.
Yeah, this is Jay Butler. Maybe I'll take an initial stab. I mean, one of the biggest barriers is the various types of challenges that are presented for getting access to prenatal care. But maybe the questioner would like to elaborate a little more on some of the specific barriers that they're describing.
Okay, so Larissa, if you can do that, just type it right into the chat. You can send it to the host or to all participants, and we'll take that further. Anyone else wish to comment on that? Okay, we have a question from Geraldine Dossier. Given mandatory reporting requirements and other, excuse me, and other criminal justice and social service consequences for pregnant women with substance abuse disorders, how can public health and clinical providers work with the criminal justice and child welfare system to encourage patients to seek SUD and prenatal care?
So I can speak a little bit from our experience. We did have a law that sunset this year that required essentially criminal reporting of mothers if their child was born and had NAS and they had not sought treatment. We were able to show with some data that there was a correlation. Again, we couldn't show causation, but we were very careful to measure when women accessed prenatal care, and we did see essentially a decrease in seeking prenatal care and early prenatal care during the time that law was in place. And so I think that was helpful to have that data, really to be able to show to our state legislature. And I also think, you know, one of the, just in thinking through some of our challenges, our CPS, so CPS is DCS, Department of Children's Services here. One of our challenges has been that they have been so overwhelmed with referrals for NAS that they are really rethinking how they are triaging these cases, and there has been a fair bit of discussion about this, both in better resourcing DCS, but also in reframing conversations around really providing support for the family as opposed to punitive punishment for the family. And so they have instituted what they call a single team, single plan, which has provided essentially a local collaboration of multiple different agencies, so that would always include DCS for these NAS families, and also would include potentially early intervention services through the Department of Education as well as Department of Health. There may be some other human services that a family might be eligible for, but really to create kind of a one-stop shop for NAS families and to try to streamline care for them. And again, with the mindset of providing support for families and not punishment for families. And so regardless, that's been a real struggle that we've had in really changing cultural mindset around that to promote healing and substance-free opportunities for women going forward.
Great, thank you. Larissa has responded to our request for more information about her question, and she's asking how are women monitored or entered into a monitoring system in early pregnancy, assuming they do have a substance abuse disorder? How are they being entered or monitored?
So there's not, at least for us, not a state system for monitoring those women. It's really, as they're identified by a clinician, they then have that clinical responsibility of connecting those women to care. I think she was talking about clinical monitoring and not, a DCS kind of monitoring. I'm not sure if that answers the question, or if Dr. Butler has experience from other states.
Yeah, and I'll just make the same comment for my own state, is we don't have a registry. In fact, we've even been hesitant to even take the step so far as making NAS a reportable condition, because we do have concerns about there not being any obstacles to care that are under the classification of Big Brother is watching. That doesn't mean that I'm speaking for or against making these reportable conditions or even having registry type monitoring. In terms of clinical monitoring, I look primarily to the clinical guidelines that the providers are using, but I'm not sure if that's what you meant by monitoring.
She's added, is it only probation or parole referrals in terms of substance abuse? And I think she's potentially not referring to the clinical situation. I'm gonna move off that, since I think I'm a little confused about that question. The direction of those questions. And I do have one more question that I think would be really very interesting to all of us. Is there a way to track the babies born with NAS? So I'm assuming the person is talking about either nationally or state-based, but for tracking the percentage of births in each state and across states. Do we have the capacity or the ability to collect that kind of data at this point? And Dr. McDonald, you shared some of your data and said it was sort of, reported with some delay, which is something we've all been challenged with in our IAM-COIN data collection. What's the situation with the NAS data in other states, maybe?
So So I think, are we talking about like outcomes monitoring?
I think they're talking incidence or prevalence.
Okay, yeah, I mean, that's really why we developed our surveillance system, was to remedy the problem of timeliness of data and type of data that we were able to collect. Other states certainly have other experiences. And we looked at outcomes monitoring really in a different way, not on a case-by-case, but in matching this through other data sets.
Yeah, and this is Jay Butler. I'll just add, if the question is really talking about surveillance, I mean, fortunately, the administrative databases using the ICD-9 and ICD-10 codes are fairly straightforward. The challenge is just how sensitive and specific those tools are, but just in terms of an easy, blunt measure to compare state to state, or even within state to identify hotspots, as Dr. McDonald was describing, I think this can be pretty useful.
Great. Okay. I think that's about the end of our questions. I'm going to turn this back over to Lee and let her close us out, unless any of the speakers want to make any last comments.
Thank you so much, Pat, and thank you so much, everyone, for your participation in today's webinar. We need to thank today's speakers, Ms. Mackie, Dr. Butler, Dr. McDonald, Ms. Bashir, Ms. Pliska, and of course, we'd like to thank ASTHO for their sponsorship and partnership of this webinar. NICHQ's next Expert Series webinar will be on September 18th at 4 o'clock EST, focusing on state Medicaid strategies to improve women's health services and perinatal outcomes. We hope you can join us for that webinar on September 18th. And please note that upon exiting this webinar, you will be taken to a quick survey that we hope you can complete about your experience today. The slides and recording from this webinar will be distributed in a few days to everyone who registered. So if you had colleagues who were unable to make it, they will receive the recording and slides. And of course, everyone who attended will as well. So with that, have a great afternoon, and this concludes the webinar. Thank you.